All right, this is the review for um, exam two and the lecture component for Biol 1220 or AP2. And so we'll begin here. It's just basically me talking. And again, what I typically do with these exams is I'm sort of looking at the exam questions, gives me a chance to review the exam myself. I may actually add a few little components. If I do, I'll send you a subsequent brief recording to add to it. So, and this one, remember, is basically focusing on two chapters, 17 and 16. One's the blood, one's the heart. So we start, well, it just so happens that we start with the heart on this one. So you have to understand that it's this recurring theme of hollow organs, and even in the heart and blood vessels are hollow organs in the sense they have three layers. So there's always going to be a lining layer, which in the heart is the endocardium, a middle layer, which is the myocardium, and an outer layer, which is the pericardium. The predominant area in the heart, obviously, is the myocardium. That's really it has the most anatomy, the most physiology. The internal lining is just slick, smooth surface, and the external is really just another layer of protection. Plays a role with a certain amount of secretion of lubrication to allow the heart to move and limit friction. So we have to know the major vessels around the heart, which are certainly the incoming vessels, which are veins in nature, because it's coming back to the heart. You have the superior and inferior vena cava, and also the vessels from the coronary sinus all enter by way into the right atrium. The vena cava, both superior and inferior, are by far and away the largest, and the largest of all of these is the inferior vena cava. The coronary sinus brings back all of the blood that's been came from the coronary arteries, collected, beg your pardon, by the cardiac veins and returned by way of the coronary sinus. So, and then you have to know the internal structures as well. The exiting vessels are by definition arteries. So you have the pulmonary trunk line from the right side of the heart that becomes the right and left pulmonary arteries, and we have the aorta. And as we get into the blood vessel part of the program, which we did a little bit in laboratory, we'll look closely at all of the different vessels uh, and did. But that'll be on the blood vessel portion of the exam, and that's going to be on the third exam, not this exam. That's there. So for the time being, you just have to know the exiting ones are the pulmonary trunk or pulmonary artery. I've seen both of those terms. And then, of course, the aorta itself. And we'll get to the valvular structures shortly with regard to that. So you have atria and ventricles, and you have divided. You have four chambers that are all have divides between the right and left atria. You remember we have that fossa ovalis, was really a tiny opening called the foramen ovale, not unlike what you saw in the same term we saw in bone, and that's so blood could flow directly from the right side of the heart to the left side of the heart in prenatal environment because the mom's lungs are being used. So you bypass the baby's lungs, which effectively aren't functional even though they're developing. And so then we look at the valve structures to make sure there's one way flow between both the right and left atrium and ventricles, respectively. On the right side, it's tricuspid because it has three leaflets, and on the left side, it's bicuspid. They work similarly, they're just different anatomically. Of course, the valves that are exiting by way of from the right ventricle and the left ventricle are the semilunar valves, known as the pulmonary or pulmonic semilunar valve, and the aortic semilunar valve, and they have three cusps, and they're named because they look like half or partial moons would be the way to describe it. The big deal with both the pulmonary artery and pulmonary veins in the adult, okay, they're the only vessels that kind of flow a little differently in the sense that the pulmonary artery flowing away from the heart, which arteries do, happens to contain deoxygenated blood. And by the same token, the pulmonary veins are the only veins that contain oxygenated blood as they're returning the blood to the left side of the heart from being oxygenated in the lung. So that makes them unique. Uh, So when I phrase the question, understand we're not looking at the fetal blood vessels and the arrangements because the umbilic vein and the umbilic artery are different in that. And we focus a little bit more on that in repro physiology down at the end of the term. So the chambers of the heart are very, very muscular, but much more so on the left than on the right, probably you might recall the dissection between 3 or 4 times to 1. That's because there's so much more ejection pressure on the left than on the right. And understand, like a lot of organs, like the kidney and various other organs surrounding the intestines, there's a fair amount of fatty tissue. A lot of times that's a pathway for blood vessels and lymphatics and nerves, and around the heart and the kidney, particularly, there's a certain amount of protection that they afford. So it's not. Oh, so it's not the fact that you have fatty around your heart doesn't mean you're unhealthy, because we all do. Obviously, when we think about an unhealthy heart, we begin to see more fatty type depositions in the muscular layer, and that's due to either a disease entity or a viral entity or something, or a hereditary entity that causes problems. So don't forget the conducting system. So effectively, just to set the stage, there's three kinds in the myocardium. There's really three kinds of tissue. There's structural tissue, which allows the anchor points for the valves and the anchor points for the vessels entering and exit. Okay. And surrounding and anchored on, and all the muscularity is anchored to those as well. And then you have the contractile tissues, which is the myocardium. And then you have cells that are similar, but they're easily they easily depolarizable, and they are effectively the system that governs the rate of the heart. So they're non-contractile cells, and that's the system where we call the conducting system. So conducting is non-contractile cells that have the ability, in many instances, to generate their own uh, action potentials because of having leaky sodium channels that are always open, and they never really settle at a resting point. They immediately start to leak sodium, and it comes up to threshold, and it depends on the rate. So you need to know all those structures. You have the SA or sinoatrial node in the right atrial wall. You have the AV node or atrioventricular node in the interatrial septa. In the atrioventricular septa, we have the atrioventricular bundle, also known as the bundle of His, which is a proper name. And then and after it divides, and this is really the only connection between the atria and the ventricles from an electrical standpoint. And then as it divides, we call them bundle branches, one on the right, one on the left. And then lastly, what they used to call Purkinje fibers, now they call it the subendocardial conducting network. And this goes from the apex of the heart and surrounds the heart in such a way that it facilitates the effective contracture and the expelling of the blood in the appropriate manner from the ventricles into the pulmonary artery, into the aorta. Okay. So, again, when we're talking about electrical activity, that's depolarization, firing, and repolarization, resetting so it can fire again. They precede mechanical activity, which would be contractions and relaxation. But the reality is the names that we use are systole and diastole. So systole is the contraction of muscle, and diastole is the relaxation of those muscles that are there. And because of the mass of the muscles, the left side of the heart obviously ejects at a much greater pressure and force than the right side of the heart. And indeed, that's the idea. Yeah, the left side of the heart's going to force it to travel around the body and still propel it into the veins, and then allow other mechanisms to assist the veins in returning to the heart, like valves and like muscular activity that we discussed. On the other hand, the right side of the heart is comparatively low pressure. It's designed to take a relatively slow journey through the lungs so it can get maximum oxygenation. It doesn't need all that time, as it takes just fractions of a second. But by design, those passageways would be really in trouble if there was overpressure. And that's kind of what happens when there's back pressure in the wrong areas. If the left side of the heart fails, the back pressure goes into the lung, fluid leaks out of the blood vessels, and you get something called pulmonary edema, fluid in the lungs, and you can't breathe because it's almost like you're drowning in fluids. And if the right side of the heart fails, well, what happens then is we can't even get the fluid to the lungs, so it backs up first into the torso and then typically into the extremities, particularly the lower extremities from gravity. We call that edema. Okay, not pulmonary edema, which is a very specific term. And so what happens when there's damage, when this occurs, is typically when we see damage to the heart muscle itself. And certainly the most frequent cause is what we call a heart attack. Now, chest pain or left arm pain or difficulty in swallowing, all of these things don't necessarily mean a heart attack. We call that angina pectoris, chest pain, effectively. When a heart attack, which is known as a myocardial infarction, is very specific. An infarction is death of tissue from lack of blood supply, period. So tissue has died. Does it mean that the person's going to die? Not necessarily. Does it mean they're going to have permanent problems? Not necessarily. Could it be a very mild heart attack, sometimes referred to as an event? Possibly. And there may be very limited limitations other than whoever had this, man or woman, would have to obviously be aware of what's address the causes, whether it's lifestyle change, they're smokers, they're drinkers, they eat too much, they don't exercise, blah 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 blah. But infarction means death of tissue from lack of blood supply. Just in the brain, a stroke is a cerebrovascular infarction. It's lack of blood supply to a part of the brain. So, and again, these are not. It doesn't always have to be a complete blockage. It can be absolute or relative. In the heart, we see that when somebody's vigorously exercising and the blood vessels can't deliver enough blood and therefore oxygen, and the heart muscle succumbs to it. That's typically that thing that we see in people out shoveling the first big winter storm. You have to know the electrocardiographic waves. The P wave signals atrial depolarization. The QRS, basically it's ventricular depolarization, but it's such a large signal and wave that it obscures the atrial repolarization. And then the T wave is ventricular repolarization. So understand that that's what we see. And again, don't confuse these with systole or diastole. They're not electrical, they're mechanical events. So you need to be familiar with that. And so there's a couple of areas with that conducting system that can generate their own beats. So if the pacemaker fails, okay, the atrioventricular node, then we call it a nodal or a junctional rhythm, is you're able to survive, but you can't do very much because you're looking at maybe 50, maybe top 60 beats per minute. On the other hand, the subendocardial network, the old Purkinje fiber, is only about 30 beats per second. Can't do anything like that. And so you need to be familiar with this. So when we talk about regulating the heart, the predominant one is the sympathetic system is only there for fight or flight. Our hearts would have a rate more than 100 beats per minute, but what happens is the healthier we are, the more input you get from the parasympathetic system. The parasympathetic governs, it controls, it limits the heartbeat, it slows it down, for lack of a better way to express it. And healthy people can even have heart rates that are under 60, particularly athletes or people who are very, very fit, depending on the activity they do and their lifestyle and genetic factors are there. In general, 60 to 100 is a normal range, but you want to be in that 60 to 80, not the 80 to 100, unless there's special activities. You can go under 60, but when you start going, nothing over 100 is bad. Those higher numbers is bad. And there's a lot of problems with it. A lot of times we'll listen to the heart and we'll hear murmurs, which are valvular defects or abnormalities that cause unusual sounds. So they call them murmurs. There's a lot of specifics to the sounds that I don't delve into, but valves can either be too taut or narrow. We call that stenosis. They can be too weak and they don't close properly, or they can be so weak and so damaged that, as you recall, those tendinocordinae, the tendinous cords, or chorda tendineae rather, or tendinous cords that are emanating from papillary muscles, outpouchings of muscle in the interior of the heart, that are designed to hold the valves so that they can close successfully and not basically succumb to the pressure and kind of blow out in the other way, so they can protrude into the atria, which is bad. They're not supposed to. That's called a prolapse. That's the worst part. And so, yeah, and you should know a bit about cardiac output, which is typically around 5 to 6 liters per minute. When you talk about cardiac output, it's milliliters or liters per minute. That's how we're looking at a volume of material that's expressed. And it's based on two things: heart rate and stroke volume. The heart rate typically averaged between 60 and 80. The stroke volume, if you remember, the ejection fraction is about 57% or 70 milliliters ejected. Remember, the ventricles hold on to about, ball game, about 4 ounces. And we only eject slightly more than half, but that's still a sufficient amount of efficiency. Fight or flight involves the release of epinephrine and norepinephrine. They are considered positive inotropic, which means force of contraction, and chronotropic, which means heart rate agents. So they increase the force of contraction and they increase the speed of the heart rate, or the number of beats per minute that are there. Whereas the vagus doesn't impact force of contraction. The acetylcholine from the vagus nerve, all it does is reduces the rate. So it's negatively chronotropic. And there's other anatomical aspects with the heart. The atria are really relatively small, but they have expansion chambers that look like little ears, so we call them auricles. Okay, and so they protrude as sort of like modified entry chambers would be a way to describe it. When they're empty, little ridges appear because they sort of fold onto themselves. They're called pectinate muscles. And just so don't confuse those with the papillary muscles, which are in the ventricles and are part of what they call the it's going to come to me, it's on the tip of my tongue, of course. It's sort of like the, the trabecular kind of pattern, little nooks and crannies that are inside. And I'll come to that name as soon as I recall it. And I'm looking at the exam. I'm not really looking at the notes or the PowerPoints with regard to this. So that's important. Remember, the ejection fraction is not a whole lot more than half. And the whole idea when somebody has had a heart attack or is diagnosed with partially clogged or clogged blood vessels, it doesn't always have to be surgery, though sometimes it is. The rehabilitation we do, that's where aerobic activity comes in. That's the idea. You want to stress your heart scientifically, not excessively. And by doing so, you'll encourage the heart to build up collateral channels, extra pathways for blood. You'll make it stronger. You'll lower your heart rate. So you're going to, by doing so, you're going to develop collateral channels. You're going to decrease the heart rate. And hopefully you're going to increase or optimize cardiac output. Okay, the beats will be slower, but this heart will be stronger, and you can get a better amount of ejection. So cardiac output increase is the goal, and efficiency is the goal of that. That's there. The coronary arteries, there's only four to remember. Coming off the left is the anterior and interventricular artery, surely the largest, and they follow down in that interventricular septa. Also coming off of that is an artery that circumflexes or goes around in the back, sort of sideways. On the right, you have the right coronary artery, which continues on to be the posterior interventricular artery, and another artery called the marginal artery that goes along that right-sided border of the heart. Okay, that's there. So be important to remember those. And we see the coronary arteries, the heart feeds itself first, so the coronary arteries are the first vessels that are given off after the aortic and semilunar valves. So, and sometimes you get lucky on the dissection. You can see, I don't remember if we had one of those, but you can see little openings just past the valvular structures. As you recall, the veins don't return the same way. Again, they've come into something called the coronary sinus, which enters the right atria. And we want to look at some of the changes vis-a-vis the cardiogram. Okay, so we look for particularly changes in the T wave. Okay, and because that's ventricular repolarization, it indicates ventricular damage, and that's typically a very significant sign. Okay, so we see what they call ST elevation, ST depression, and you see a lot of irregularity in the T wave. You even see it in the Q wave. When we look at the P wave, we particularly look at that interval between the P and the R, from when the atria depolarize until effectively the ventricles depolarize. That should fall into that roughly a tenth of a second to maybe a fifth of a second when you count the little squares that are there. And understand that if it takes too long, that's a degree of what we call a heart block. So you can have a first degree heart block, which is a delay. You can have every other beat or every third beat going through. That's secondary. Or you can have it where the atria really don't work at all. That's when you get that nodal or junctional rhythm. So I think all of that's part of it. Remember the heart sounds. Can't forget those. The heart sounds, the loudest of the lub dub is the first one. That's the loudest one. That's the atrioventricular valves, the tricuspid and the bicuspid slamming together. And again, nothing for the bicuspid is the mitral valve. And then the second heart sound is the aortic and pulmonic valves, the semilunar valves closing. So that's all part of it as well. So that's a lot of the heart material. We move on to the blood material. Remember, we centrifuge. That's how you separate blood. Because effectively it's a suspension. So you could let it settle, but when you let it settle, the potential is for clotting. So in order to accelerate that, we centrifuge. That's what they do in the blood bank. And you remember that test tube that came out of the centrifuge in the illustration in PowerPoint. You have the supernatant liquid, the stuff, the light stuff's on top. That's the plasma. The heavy stuff are the packed red cells. They go to the bottom, obviously with a little bit of moisture and liquid in them. And then in between them, you have the buffy coat, which has a combination of white blood cells and platelets, because they're, again, formed elements. They're just not as heavy as the red blood cells, which are laden with hemoglobin. And the plasma is basically a liquid with stuff dissolves in it. So it's not very heavy at all. I mean, you got some proteins in it, obviously, but it's not heavy by any stretch. So remember the roles of the proteins. 60% of them are albumin. That's principally, its big role is colloid osmotic pressure. It also is an agent that can hold on to certain materials that are in there, but by and large, and so you can be involved in certain amounts of transporting, or call it a transport protein. But the big deal is that colloid osmotic pressure. It holds the fluid in the blood vessels and resists blood pressure. And remember, we learned that whole thing with the capillaries recently in lecture. It's important because not only does it allow stuff to come out, but it helps to pull things back in once we get into the vein side and the arterial pressure drops. Whereas the globulin fraction, you have ones that are immune oriented, your immunoglobulins, which is the gamma fraction, but alpha and beta globulins are involved in transporting fats, very, very much so. So when you hear about LDLs and VLDLs and HDLs, all these density of lipoproteins, the protein that's involved holding on to that lipid happens to be in that what they typically in the beta globulin category. When we look at red cells themselves, remember that red cells predominate by perhaps 1,000 times more than white blood cells. Maybe not quite. Maybe half that. Maybe 500 times more than platelets. Not that that's a big deal, but the red cell is the predominant cell. When we look at the blood and the cellular fractions, a biconcave disc sheds its nucleus as it matures. It's basically a big bag, interestingly shaped for hemoglobin. And the hemoglobin carries the oxygen. That's its job. Okay. Whereas the only true platelets are fragments of cell membrane with some protein granules in them that are all about clotting. The only true cells are the white blood cells, and the white blood cells we know that because they have a nucleus. And again, the shapes of the nucleus and it really and the presence or absence of granules is really significant. So the most common of all the white blood cells, roughly 50 to 70% normally in your bloodstream, are called neutrophils. There's other names for them called polymorphonuclear leukocytes because it always has between 3 and 6 lobes of folds. So when the nucleus folds, the shape, we see little lobes, even though it's one large nucleus. It's just folded, at least the way it appears microscopically. And it's all, we call them bacterial slayers. They fight bacterial and bacterial infection. They have granules that stain. Okay. It just so happens the neutro portion of it is because they stain neutrally. They don't have a distinctive color, either very red or very blue. They're sort of a pale or a lilac color is the classic definition. So again, little bits of membrane and granules are the platelets. White blood cells, the lymphocyte looks like it's almost like a giant nucleus with a scant amount of cytoplasm. They're bigger than red cells. They're smaller than monocytes, even though they're similar. And those granules are present, but we just don't see them when they stain. So they're called agranular, even though there are granules within them. Okay. So I think that's an important, and so we look for them. Typically, they're increased in viral infections. So when someone would have COVID, for instance, likely they would have what we call lymphocytosis. Where we diminish them is something like AIDS. Unfortunately, that's an immunological disease where your immune system collapses and you have insufficient amount of those. And we get into specifics of which one is which. We look at different kinds of problems with red cells, and the most common problem is by far and away that mean why people are anemic or have a lack. Anemia is a generic term which means lack of cells, but because it just predominates because there's so many more red cells. So the implication is when we say anemia, we look, so with white blood cells, we'll say leukocytopenia, and which there's too many, we'll say leukemia. So the term anemia is more about insufficient amount of red cells. You recall I showed you my blood tests, and unfortunately, I have a certain degree of this, a rather significant degree, but fortunately, I can deal with it. But the most common types are iron deficiency based, and most commonly, they have to do some kind of either dietary or, in my case, blood loss, which can be external or internal. So that's where pernicious anemia is very specific. That's called a macrocytic. That means B12 is necessary for the cells to mature. They get smaller as they mature. So when they don't have enough B12, they stay large. That's called a macrocytic anemia. I have a little bit of that right now going on as well. And where iron deficiency anemia, basically the cells are too small. We call that a microcytic anemia. Plus, they're much paler. They're not necessarily as red that are there. So there's a ton of oxygen carrying capability. Each red cell has four, basically, effectively four chains with quote unquote hemoglobin chains. You have four protein chains that two alpha and two beta with a heme unit embedded in each one. So theoretically, each hemoglobin molecule can carry four oxygens. You have about a quarter of a billion with a B in each red cell. So you have each red cell can carry approximately a billion molecules of oxygen, and in a microliter, you have 5.5 million. In a milliliter, you know how small that is. It's like 20 drops of fluid, 15 to 20 drops of fluid. You would have 5.5 billion molecules of 5.5 billion molecules of oxygen theoretically could be carried in a tiny drop of blood. Imagine that. So it's really remarkable in that regard. So we have other cells that are white blood cells, like the lymphocytes. The monocytes are the largest. They become macrophages when they leave the bloodstream, and you can see them because they typically, I don't know, they're large. They have either a kidney or a U-shaped, because they look a little bit like a lymphocyte, but you can see a little more cytoplasm, and they're certainly distinctly bigger. Whereas the other, and so they're considered agranulocyte because they don't stain. Whereas the granular aspect of things comes back with eosinophils and basophils. Eosinophils have stain reddish. They have a lot to do with allergies, but they have really a lot to do with parasitic infections like worms. If your dog would have worms, or a pet, or other malaria is a parasitic infection, but they also play a role in allergies. And then the basophils, which have blue staining granules, and it's almost like a shower of granules. Both the red, the eos, and the basos have typically bilobe nuclei, but it's the granules, the vivid and distinct appearance of the granules, which really defines them. But the basophils become mast cells, which are granules mostly of histamine, sometimes with heparin or other chemicals, and they play a pivotal role in allergies, and particularly severe allergies like anaphylactic shock. When we deal with the clotting cascade, and remember, the one that we hear a lot about, and what most people think about, the clot, they call it tissue factor or tissue thromboplastin. And what that is, that's what's released when cells are damaged. So when you cut yourself, when you scrape your knee, when you clunk yourself, I mean, you're going to do cellular damage inside, and that rapidly triggers the extrinsic clotting cascade. And that's a much faster cascade than the intrinsic, which is typically from exposure of underlying collagen in blood vessels in the interior of blood vessels that are damaged. What happens? The cells are damaged for whatever reason. Okay, And again, the analogy I use is just like a roadway that's traveled all the time. It's a tiny defect that develops. And what happens? A little bit of collagen is exposed, and we form a clot, and and repair. We repair them slowly because you don't want to cause dramatic clotting all throughout the system, because that could really, potentially be extraordinarily damaging to the person. So the intrinsic clotting system works all the time, but slowly, where the extrinsic works infrequently. Hopefully, unless you're very clumsy, we use very infrequently, but uses much more rapidly. So the intrinsic starts with tissue thromboplastin, and it's a shortcut to get to factor 10. And then once factor 10 is activated, you might recall factor 10 activates called prothrombin activator once it's activated. And what it does is it converts a chemical in the bloodstream called prothrombin, which is normally inactive, to thrombin. And once the thrombin, that protein acts as a catalyst to change fibrinogen, which is dissolved in the bloodstream, into fibrin, which is no longer dissolved. It changes its shape. It comes out like a fishnet. It traps a whole bunch of red blood cells, and a clot forms. The intrinsic clotting cascade has many, many steps. That's why it takes so much longer. The most common deficiency that we see hereditary is factor 8. That's hemophilia A. There's factor 9, which is hemophilia B. And again, a lot of these clotting factors have a lot to do with vitamin K. There's a lot of vitamin K dependent factors. And sometimes with people with clotting problems, we'll use vitamin K, and they'll take greater amounts of it. They don't clot as efficiently as they should. If that's one of their limitations that are there. I do remember the composition of the proteins in the plasma, the relative amounts: 60% albumin, 36% globulins, 4% fibrinogen have been the numbers forever, and I don't suppose they're any different. So again, don't forget about the different kinds of cells that are there. Beta cells becoming mast cells, macrophages, and monocytes. And this happens when they leave the bloodstream, as white blood cells do, because they come in the bloodstream and then they leave it. We know that fibrinogen is always dissolved in the plasma. That's where it's carried. So it's in the plasma component. It's not in the platelet. It's not in the buffy coat with platelets and white cells. It's certainly not in the red cell component. We look for the idea of granulocytes versus agranulocytes because the granules stain. There are granules in all of them. The question is, are they visible microscopically when they stain? Okay. And I think all of that's important. And remember the sort of that never let monkeys eat bananas: neutrophils, lymphocytes, monocytes, eosinophils, basophils. Okay. And let's see. Oh, so again, remember the prothrombin to thrombin, and remember the fibrinogen to fibrin is what that leads to. So that activated factor 10 becomes the prothrombin activator, converts prothrombin to thrombin, and then thrombin is the catalyst for fibrinogen to fibrin. Well, when clots form, we have to get clots dissolved, or every time a clot forms, it would never go away. So within a couple of days, and using the action of some of the clotting factors, they serve to activate something called plasminogen to plasmin. And the accumulation that becomes active in a couple of days after a clot forms is a clot buster called TPA, or tissue plasminogen activator. We make it genetically. It's a comparatively simple protein or polypeptide. It's a short chain of amino acids. And by making that, we can cause clots to bust electively if we can catch a heart attack or a stroke in its early stages. So that comes from genetic engineering. That's part of it. And so far, that's everything I have. I think that's relevant. I think there'll probably be a handful of more questions, and I'll send you a second dictation that'll be fairly brief, maybe 5 to 10 minutes, that type of a thing. So thanks very much, and I will get this sent to you and post it. And of course, I'll tell you exactly where it's going. Thank you. Goodbye.